Hello and welcome MedSurge 2 NU133. This PowerPoint is a supplement to lab, and we are going to talk about IV therapy and blood administration. Um, let's get started. Um, peripheral IV devices. Typically, what we use now are over the needle catheters with safeties. The purpose, we use this for infusion of IV fluids, electrolyte replacement, for giving IV push drugs or IV piggyback medications. We can also use these to transfuse blood products. Um, they are numbered gauges, and the smaller the number, the larger the needle is. So typically what you'll see stocked on a nursing unit is like a 14, 16, 18, 20, 22 gauge. Probably the most common used gauge IV catheter for a medical surgical unit is going to be your 20 gauge. In the emergency room, I bet you they go with 18 gauge more likely. If you are dealing with an elderly patient or a very frail older adult, you may go with a 22 because it's a little bit smaller. Um, the color of the hub corresponds with the gauge. So a pink one is the 20 gauge, a blue one is a 22. So that's another way to look at it quickly and just say, okay, what size is this? Then we need our peripheral IV start supplies. So usually most hospitals and places stock the IV start kit. So you can see the components that go in a normal kit. We've got a tourniquet, that's the blue thing. We've got a tegaderm, which is for protecting the site. We've got an alcohol swab, some 2x2s, tape, and then the black thing. Usually what most places use anymore is chlorhexidine. It used to be like iodine kind of stuff, old school. But that's what you use to cleanse the skin before you start the IV. Now I included on here skin prep. Skin prep is something you might not think about when you're starting an IV, but remember that this will help protect fragile skin, for example, in elderly patients. So tegaderms are usually pretty gentle, but elderly people or people that are on steroids can have very, very fragile, like tissue paper almost like skin. So what you can do is wipe the skin with some skin prep where the sticky stuff is going to go, and that helps protect elderly skin from tearing when you remove the dressing. Now, there are different problems that can happen with an IV, and this diagram shows you the three main parts. You can have phlebitis, you can have infiltration, you can have extravasation. Phlebitis is an itis, so it's an inflammation. Infiltration is leaking of a non-vesicant. Extravasation is leaking of a vesicant. So I would refer back to this because it's a nice little diagram, but I'm going to talk about more of these. So the first complication I want to talk about is infiltration. So infiltration is caused by several different things. It could be caused by improper placement of the peripheral IV, or it could be that the catheter got dislodged. What we're going to see is swelling, discomfort, burning, or tightness. They could have skin as cool and blanching. The IV might beep a lot, saying that it's not infusing because it's no longer in a vein the way it's supposed to. Infiltration, how do we prevent it? Choosing a good IV site, using good technique when starting an IV, and then of course, checking out that IV site frequently. Is there any redness, any swelling, any tenderness? Telling the patient to let you know if any of those problems occur. If you see the signs and symptoms of infiltration, what do? Stop the infusion, start a new IV, remove the old IV. We're going to also elevate that limb That will help decrease any swelling. We're going to check to make sure the perfusion is adequate below the IV site, or we call it distal to the IV site. And then you're going to go back and check that site frequently. This is a picture of an infiltration. Then we can have phlebitis. Phlebitis is the itis, so that's when we're going to have the redness or tenderness. It may be swollen as well. So that plastic sheath has been dislodged, it's out of the vein, and it's irritating those tissues. Again, prevention is the best thing to do to just prevent phlebitis. If the site is cool and swollen, we again stop the infusion, put a new IV in, remove the old IV, elevate that arm, put warm packs on it, or cool packs if that helps with patient comfort. This is a picture of phlebitis. So this is why when we assess an IV site, we're looking for any sign of pinkness. Because if the pinkness is this extensive, that phlebitis has been there for a while and we didn't catch it. You want to take it out at the first signs of redness. Okay? That brings us to just flipping my page over, extravasation. Extravasation is leaking again, but the problem with extravasation is that the fluid that is leaking into the tissue is a vesicant. And vesicants are fluids that are really hard on the tissues and can actually cause tissue death. And it can also cause like infection, tissue necrosis, loss of function. Sometimes we even have to amputate. So again, what we will do is stop the IV infusion rate and the extra step with this one is that some medications, because they are a known vesicant, they have an antidote. And if that's the case, we might want to administer the antidote through the old IV catheter because then it will get into the tissue. There are some antidotes that have to be given in a series of little shots into all of the area that has the fluid in it. So you have to look up those drugs that you're giving, especially if it's a drug you're not familiar with, or an antibiotic, or chemotherapy medication, but there's additional education you would receive if you were giving chemotherapy meds. But if you have a patient that's getting chemo on the chemo unit and coming back to your unit, you need to be mindful that you need to watch for signs of extravasation. So usually if something has extravasated, we try to ballpark how much fluid do we think was infused so that we can make some educated decisions about how to treat that problem. So the healthcare provider is the one that you need to notify, and then they need to prescribe the antidote, and then typically we have to notify pharmacy as well. You have to perform frequent assessments of sensation, motor function, and circulation to the extremity that had that IV catheter in it. And then you want to use the manufacturer's recommendations to whether you use cold or warm compresses. This is a picture of what happens in extravasation. Vesicants can cause tissue damage and tissue necrosis. The Infusion Nurses Society practice of standards in 2006 state that drugs that have a pH that are less than 5 and greater than 9 should be infused through a central line. So there are some medications that we just do not give through a peripheral line because they're too risky. Um, some examples are chemotherapy medications, vancomycin. Ideally, potassium would be given through a central line. Dobutamine, diazepine, dopamine, Phenergan is on that list. Uh, Contrast agents. So if any of these things are given through a peripheral line, that's an extra red flag to me that I need to really be mindful of what's going on with that infusion beyond if they were just getting normal saline. Okay, so you just want to be thinking about what kind of medicine are we dealing with. And if they do have a central line, by all means, don't put these meds through a peripheral, put it through the central line. And if they have to have any of these medications that are vesicants for more than a day or two, talk to your doctor about getting a central line placed so we decrease the risk of this happening. These next slides, this is a picture of an extravasation. That black is tissue necrosis. So this one, they had it in their arm. Here's one where it was a hand. And so you can really see how this could lead to loss of function and or need for amputation if this happens. So pretty serious. Hopefully none of you will ever see this in practice because we're just good enough to prevent it from happening. So we've touched on central lines. So let's talk about what is a central line. So this slide has a picture of several different central lines. We've got a central venous catheter, we've got a PICC, we've got an infusion port. All of those are considered central line because of where the tip, the end of the catheter is located. And where that end located is in the heart. The tip lies in the superior vena cava, and that blood vessel is so big and that blood flow is so generous that it's almost like a waterfall. There's a lot of blood flow, and because of that, it can tolerate these really harsh medications. So, there are multiple types of central catheters. I'm not going to test you on the ins and outs of every kind of central catheter. What I want you to know is the key words that give you a heads up. Hey, this is a central catheter. So, a PICC, a triple lumen, a double lumen, CVC. You can also have something called a Hickman or a Grochon. All of those are just descriptors for a type of central catheter. And PICC is the most common that you'll see on medical surgical floors. In the ICU, you may see a few more central venous catheters. But you could hear that someone has a Grochon or a Hickman and just know, hey, that's a central catheter. So there are some rules about that. So this diagram shows you what to flush with and how frequently to flush it. I'm going to tell you don't memorize this table because depending on the manufacturer of the catheter and the facility that you work at, they may have different guidelines. The big thing to take away from it is you've got to flush these things to keep them patent. Okay? So let's talk a little bit more about PICCs. PICC stands for peripherally inserted central catheter. And usually it's in the right or left upper arm. And then it goes up the brachial into the superior vena cava. And the things that you need to know as a staff nurse is not how to place these. You're going to be specifically trained to place these. What we do is use them and make sure we assess them. So what do we want to assess? Well, we want to assess the insertion site. We want to assess the skin and the insertion site for any redness, drainage, including blood, swelling, anything that indicates some sort of infection or clot. Those would be reasons not to use a PICC and to notify the PICC team. We also want to assess how much of the catheter is exposed because that should be consistent. Sometimes people pull on their PICC, and that's not good because remember we want that tip to be in the superior vena cava, and if you pull it out just a little bit, it's not where it's supposed to be. So that increases the likelihood of complications and problems. So assess that insertion site. The dressing over the insertion site should be a tegaderm and it should be securely stuck to the skin. If a corner is peeling up, you either have to notify your PICC team to come and do a new PICC dressing, or you do what we call reinforcement. Reinforcing that dressing means putting tape over top of it because a PICC dressing is a sterile dressing. There's specific rules around doing that dressing, and your average staff nurse can't do a PICC dressing change in most facilities. So what we do is we put more tape over top of it to keep it secure until a specifically trained PICC nurse can do that dressing change. When we discontinue PICCs, some places the PICC nurse does it, some places the staff nurse can do it. The most important thing is to measure how long the catheter is when you pull it out to make sure none of it is retained in the blood vessel. Some patient education for anybody that has a PICC line is we tell our patients not to do any lifting while that PICC is in place. No carrying of heavy objects, no carrying of children, of grandchildren, groceries, no playing tennis, any of those things. Because some people do get discharged to home with a PICC line in place. So that's assessment on the body. Some assessment of the catheter itself and care of the catheter. You only use a single-use 10 ml syringe to flush a PICC line. Because of the pressure that is created by using a smaller syringe, you could rupture or damage the catheter. So anytime you go to flush a PICC, you're going to use a single-use 10 ml syringe. The volume is important because it should be twice the volume of the catheter length. So that means you've got to use all 10 milliliters to flush. So if I'm going to go give a medication through a PICC line and it's an IV push, I'm going to take 2 10 ml normal saline flushes in the room with me. I'm going to clean the port, very good. Scrub that hub is what they usually say. Flush with the 10 of saline, administer my med using the proper push rate, and then flush behind it with another 10 milliliter syringe. And you should only use normal saline for your flushes. So if a PICC is being used, a good general rule of thumb is flush with 10 mLs before and after every use. If it's not being used, you want to flush it every 24 hours. So my caveat for this rule is that this is a guideline. Depending on what facility you work at, they may use different guidelines than this. But flushing it is very important. The other piece that goes with flushing is using a pulsative or stop-start method. So you push in 3, stop. Push in 3, stop. Push in the last piece, stop. What that does is it creates turbulence within the catheter that helps kind of push things through a little bit more effectively. Okay, so this is a picture of the insertion site. Now you want to be careful because people could have a dressing that looks like that, and that might not be a central line. So you always want to make sure that this is a central line because this could be something called a midline. A midline is a catheter that they probably tried to put a pick in, and for whatever reason, they couldn't get it threaded all the way. So it only goes into about the shoulder. So if it's a midline, it's not a central line because it's not in the superior vena cava. Midlines can stay in for about 4 weeks. Um, and they are not central lines, so medications like vancomycin shouldn't go through it. Um, Midlines can actually stay in, or excuse me, picks, full picks can stay in place for a year. Okay, so you want to think about how long is this patient going to need this catheter. Um, so I already told you about no heavy lifting, no repetitive movements. Um, I mentioned before with assessing the patient, if it's swollen, it needs to be evaluated, and that's because there is a risk for blood clotting and impeding circulation. Um, and another thing is with a peripheral IV or a PICC line, if your patient complains of a pins and needle type sensation, that's a red flag that that catheter may be irritating a nerve. And we probably are going to have to either reposition it or discontinue the IV. Very important that you remember that. Let's see. Just looking at my notes to make sure that I haven't missed anything. We talked about that. PICC lines are always verified with a chest x-ray, or most commonly, I should say, just to confirm placement. So there's a guide wire that gets left in until they confirm placement, and then that guide wire gets removed by the PICC team. Okay, I think that's everything on PICCs. I mentioned just be familiar with the word Hickman. Hickman is just another type of central catheter, and this is a picture that just shows you what that looks like. Groshong is a specific type of central catheter that has these slits cut into the tip of it that you only have to use saline to flush, versus a portacath, which is sometimes called an infusiport. This is a little bit more in depth. You'll see cancer patients have these placed very commonly because they can be left in for years. And this is a port that's surgically implanted. And it appears as just like a lump under their skin. And if you palpate it, you'll feel these little bumps. And in order to access these, you need additional training. But once it's accessed, a staff nurse can use it for infusions. The important thing to remember about these is that you have to flush, and sometimes they put heparin in these just to decrease the risk of clotting, especially if it's not used for a period of time. We can also do lab draws off these, which is kind of cool. But again, you would have to be specifically trained on how to use it. And the needle that we use to access these is called a Huber needle because it's bent at almost a 90 degree. It's kind of cool. Okay, so that is our infusion component of this PowerPoint. We're going to switch gears now. And the last few slides is about blood transfusions. So if anybody needs blood, the doctor is going to decide that based on their hemoglobin and hematocrit. And what they're going to order is a type and cross. And they usually say how many units they want to type and cross. And when we type and cross, what we do is we find out what blood type the patient is. So that's the first part. That's the type. Is your patient A, B, O, or some combination? And then the cross match is What they do is they take a little bit of the patient's blood and a little bit of the blood donor blood and mush it together, and look at it under a microscope to make sure that they get along together. Okay, so that way it's safe to transfuse a whole unit. So that's a type and cross. This is another picture just to kind of remind you of what we're talking about when we talk about blood types. It's what kind of antigens does your patient have on the surface of their blood. If they've got type A blood, they've got A antigens. If they've got B blood, they've got B antigens. And so we have to match that up so that it's compatible. Again, for my class, you don't have to have this chart memorized. Next term, you will have to have this memorized for Lisa, but this just shows you a breakdown of who can receive what type of blood. So then we get to the actual transfusion of blood products. This is a very high risk activity. Blood, if it is done wrong, can kill your patient. So whenever you're going to give blood, you need to be very focused on the task at hand. So this is in a nutshell the responsibilities that we have to focus in on when we're doing blood. So usually nowadays when you draw blood for a type and cross, they put a unique identifier band on your patient. And that's a safety precaution so that people don't get the wrong blood by mistake. So we have to verify our client's ID. We've got to verify the order. We've got to double check the labels on the blood bag and the blood transfusion record. Before we ever hang blood, we have to have a set of baseline vital signs, including temperature. You've got to have an 18 or a 20 gauge needle. If it's smaller than that, it will squish the blood cells and cause hemolysis. Blood products can only be hung with normal saline, period. Blood has to be administered with a filter. So there's specific blood tubing that you have to learn where to find it on your nursing unit. And blood tubing, I've seen 4 to 6 hours as a range for how long blood tubing is good for. And you can only do 2 units of blood through 1 blood tubing. Okay, and each blood product has to be transfused separately. You can never have 2 units of blood going in simultaneously. You also cannot give any medications if a patient is getting blood through that tubing. So before we even get to that step, we've got to determine if the patient has had any previous blood transfusions, and if they have they had any reactions? Do they have any allergies? We need to confirm with 2 nurses that we have the right blood type, we have the right RH factor, we have the right patient, we have the right blood bank ID, we have the right hospital number, and the blood is not expired. Okay, so there's just, as you can hear, there are so many rules with blood. And unfortunately, a lot of them seem kind of arbitrary until you go and do it yourself. But these are so important to know and understand. So basically, after we've done all of our double checks, we've gotten our baseline vital signs, we've verified the order, we will get the blood from the blood bank. So we only have 30 minutes to get that blood infusing. So before you request your blood from the blood bank, you've got to have a working peripheral IV or 2, and you need to have your blood tubing set up and infusing. So you can see in this picture, and I'm going to click on the next picture because it's realistic. So as you can see, you've got 2 bags hanging. You've got the blood in red, and you've got your normal saline, the clear. Then there's 2 roller clamps on each of these. So only 1 roller clamp can be open at a time. So when you're setting up your blood tubing, your blood clamp is closed because you don't have the blood yet. Your saline clamp is open, and so you'll prime the tubing and the filter with the normal saline. And then once you have your blood, you'll clamp the normal saline and open up the blood, and then the blood will infuse. Okay? And that blood, the maximum amount of time you can take to infuse a unit of blood is 4 hours. And the reason for that is because blood outside of the body, not refrigerated, starts to break down after 4 hours. So remember at the beginning I said that blood tubing is only good for 2 units and is usually good for 4 to 6 hours. So if you have 2 units of blood to give and each unit takes 4 hours, you can't use the same tubing. You're going to have to use 2 different tubing. So these are some things you have to think about because no one's going to tell you to do this. It's what you have to know as a nurse to keep your patient safe. So definitely keep in mind everything I'm telling you, but if you want more in-depth understanding, I believe that this is discussed in your textbook and or the nursing intervention book. But I would probably listen to this part a couple of times. Okay, so I think we talked about all of that. One thing I want to plant a seed of is transfusing blood. Blood, each unit is typically about 350 milliliters of fluid. So if you're giving several units of blood, you're giving them basically a fluid bolus. So we need to watch for signs and symptoms that they can't handle that extra fluid. So if you notice any shortness of breath, they could be experiencing pulmonary edema. You want to watch the urine output to make sure they can pee off that extra fluid. And especially if your patient has heart failure or a kidney condition, you want to watch them even more closely. Okay. So some key points for blood products. This one column says what the blood bank's responsibility is. The other one is the bedside nurse. So some things to know is that we need to have a consent for receiving blood before we can ever start a transfusion. So that is one consent that we can have the patient sign. We have to educate the patient on the signs and symptoms to report that could indicate a possible reaction. And that is on the next slide. So what could go wrong? Well, your patient could have a blood transfusion reaction. There's 3 main types. I'm not going to test you on the specific types. And know that most of the time, blood transfusions do not cause a problem. Transfusion reactions, the key signs and symptoms that you would watch for are back pain, chills, fever, hives, fainting, bloody urine, and or fever, hives, which I think I said already, I apologize, shortness of breath, chills, changes in vital signs. Febrile reaction, allergic reaction, hemolytic reaction, all of those are possible. What you do for all 3 of these is stop the transfusion and notify the physician. And if you stop the transfusion, get a fresh set of vitals. So when you're transfusing bloods, you usually get a baseline set of vitals, and then 15 minutes in, you get another set of vitals. And that's because most transfusion reactions will occur within the first 15 minutes of a transfusion. The longer a transfusion goes on, the less likely it is for a reaction, but we have to be diligent the whole time the patient is getting a blood transfusion. So again, if you notice any of these changes, stop the transfusion, notify the physician with a fresh set of vitals. What we're going to do is change the IV tubing if the doctor feels this is a transfusion reaction. We're going to start a fresh set of vitals or a fresh set of tubing. What we're going to do is turn off the blood, flush with normal saline, and then change out everything. We're also going to treat our patient's symptoms. That could be giving them supplemental oxygen, uh, a normal saline bolus. We could also give them something like Tylenol or even a Benadryl or a steroid like prednisone, anything like that to diminish the immune system reaction if it's like an allergic. The Tylenol and Benadryl could be helpful for febrile. Again, you don't have to identify what reaction they're having. It's just that they are having a reaction. If the doctor feels as though this is a transfusion reaction, what we do is we take all the tubing with the saline and the blood attached, and we send it down to the blood bank in a bio bag, and they run additional tests on it. Okay. So the big thing is stop the transfusion, switch over to the normal saline, get a set of vitals, notify the healthcare provider, and then treat and manage the symptoms. All right, and this is it in a nutshell, what we've already said. The other thing that's on this slide that I haven't mentioned is in most facilities you have to complete a transfusion reaction form, and that just gathers information about the incidents in hopes that we can figure out what went wrong and to prevent it. And then just to remember for delegation. In Iowa, acts that cannot be delegated to an LPN includes the administration of blood and blood products. What you can delegate is you can have them help verify the blood products per your institution's policy. They can't get initial vital signs, but they can get subsequent vital signs as long as you are there to interpret them. And if anything isn't progressing as expected, you can no longer delegate the vital signs. You, as the RN, has to step in and do the vital signs yourself. Most nurses I know would rather just do their own blood vital signs just because things can change so quickly with a patient getting a transfusion. Now, I know it's kind of a scary idea, but I'm telling you, most of the time, your diligence is enough to prevent anything bad from happening to your patient. Severe transfusion reactions are extremely rare. Okay, so that was a lot of information. I really appreciate you listening. Please listen a couple of times. These are important concepts to know and understand. And this material you will be tested on the final. So I believe it's week 9. I ask you to circle around and review this again. Okay, thanks so much.